So just wanted to remind you, last class on Wednesday, a week and a half ago, seems like forever, we were talking about the transmission of the electric impulse through the heart. Ring the bell? Okay. So we had sinoatrial, we talked about sinoatrial node that since the signal travels from sinoatrial to atrioventricular, then through the atrioventricular bundle here to the Purkinje fibers. And we also traced the events that happen at each stage with changes with the contraction or relaxation of the chambers. And we figured that we can actually measure that electric current through the heart by the means of EKG, electrocardiogram. Okay? So we mentioned that there are, just kind of reviewing what we talked about to move on, two waves and this complex. So P wave, this one, corresponds to the depolarization of atria. And when we say depolarization in terms of the muscle activity, what do we talk about? Squeezing, contraction, right? Then during QRS complex right here, you have atria repolarized, so relaxing, and ventricles depolarized, so contracting. And then last, during the T wave, the ventricles relax, ventricles repolarize, and we can catch that activity as well. So EKG gives us a little bit of a glimpse into the electrical waves as they travel through the heart, and you can imagine that if there is some kind of abnormality, right, in the conduction system, it will be reflected on EKG. Does that make sense? Okay. So what, first of all, first thing that we can see on EKG, and those are examples of different electrocardiograms, is that we can get the heart rate. Correct? We can see the heart rate. So based on the heart rate, we can say that a patient has tachycardia or bradycardia. So tachycardia is when the heart rate is high, bradycardia when it is low. Are those things, tachycardia and bradycardia, are those things diseases or not? No, they're not. Say, if you are a professional athlete or you're just very fit, okay, then at rest, you're likely to have bradycardia. Does that make sense? Slow heart rate. Okay? Some trained athletes, they have the heart rate as low as 40 beats per minute. Which is, and it's normal. I mean, there's nothing wrong with them. They just have 40 beats per minute. Okay? Or, remember we talked about the patient that underwent heart transplant, and his normal heart rate is now about 110, 120 beats per minute. So this patient will normally have tachycardia, rapid contractions. But that's going to be a new normal for the patient. Say, when you are running, when you are exercising, your heart rate goes up. You essentially experience tachycardia, but that is normal for the for the activity that you perform. Make sense? Now, what else can cause extremely fast or too slow contraction? Fever. People that are feverish have higher heart rate because all metabolic processes are increased and the exchange of nutrients and exchange of gases has to be accelerated as well. Certain toxins can do that. Drugs, like coffee, sympathetic stimulation, when you exercise or when you stressed, excited, blood loss, which makes a lot of sense. Think about this. Remember I told you the cardiovascular system is the pump and the pipes. If you have less fluid in the pipes to maintain the same pressure, you have to force pump to work harder. So it will move a smaller amount of fluid through the same pipe system in a shorter period of time. Okay? Slow heart rate, parasympathetic stimulation. Okay? Generally speaking, now if we talk about controlling the heart rate, parasympathetic system controls. Okay? It keeps your heart rate at 70. Remember this table. Okay. Remember this table with inherent rates over here? The SA node has inherent rate of 100 bits per minute. AV node 50. And the bunches and Purkinje fibers and all the fiber system 30 to 40. But what is the regular, like a normal? 60, 70, yeah. It depends on the athletic, actually, the level of fitness a lot. So why it is not 100? Why it is not a rate that sinoatrial node sets? Something slows it down. It turns out that this is the vagus nerve. Okay? You see the blue nerve right here? That blue nerve delivers the motor output to the SA and AV node, constantly slowing them down. Does that make sense? So heart is essentially under parasympathetic control. When you start exercising, what happens to parasympathetic system first? It gets activated or inhibited. Parasympathetic. When you start exercising, it gets inhibited, right? Parasympathetic activity becomes low, so signals through the vagus nerve becomes less and less frequent, and SA node and AV node, well, it's mostly SA node, will start to send signals to the heart more and more frequently. At a certain point, parasympathetic control will be gone, and sympathetic nerves, they depicted here as green, okay? They will take over the control of the heart and will increase the heart rate. Does that make sense? The part of the CNS that controls the heart rate is located in medulla oblongata. And there are two centers, cardio-acceleratory and cardio-inhibitory. The name explains it all. Cardio-inhibitory center is parasympathetic, part of the parasympathetic nervous system, and it slows the heart down. Cardio-acceleratory center speeds the heart up, right? Now, if you think how it works, again, when you're scared, what's going to happen to your heart rate? It's going to go up, right? And it's a typical reflex. You have certain sensory input that makes you scared. That sensory input, after it's processed in the CNS, okay, initiates the motor output from medulla that increases the heart rate. Okay? Does that make sense? Because I will ask you that. You have to understand the roles of sympathetic and parasympathetic nervous system in controlling the heart rate. Okay? We're good. Let's take a glance at what kind of problems can we see on the EKG. Again, I'm reminding you. So we have SA node, signal goes to AV node, then to the AV bundle, then to the Purkinje fibers. Just, I'm putting that on the slide so we can refer to it for each and every problem. Nodes can become dysfunctional. Does anyone remember the cells, the pacemaker cells in those nodes? What are they? Say again. You're talking about the AV node, the backup system that sets up. Yes, but they are certain cells that are changed, kind of modified. They muscle cells that are modified. And I see what you're saying. I see what you're saying. They actually set up the rhythm, but they are not the only ones that set up the rhythm. Nervous system plays a role too. If you cut the vagus nerve, heart will still beat. Its rhythm will go up immediately. The heart rate will go up immediately. Okay? So, those cells, the pacemaker cells, they can die. As any other cells. And if they die, the node becomes dysfunctional. Especially if there's not just one cell that dies, but the entire area around the node dies. What can make it die? Myocardial infarction, lack of blood flow, cells will die. Okay? Make sense? So what happens if the sinoatrial node becomes dysfunctional? What happens to the heart rate? Wait, look at this. Wait a minute, I go the wrong direction. Heart rate slows down because the SA node sets up the rhythm. You block the signal at SA node, the rhythm becomes so-called junctional rhythm. AV node is going to set it up. Does that make sense? So that's one problem. When you don't have functional SA node, the easiest way to diagnose it is the absence of one element on EKG. Can you identify that element? P wave. P wave is gone, right? So you have QRS, you have T wave, but P wave is gone because P wave is when electrical impulse is generated at the SA node, correct? And then causes depolarization of the atrium. When SA node is dysfunctional, there's no P wave, no atrial depolarization. Essentially, atria will not contract. Okay? Another problem is atrioventricular node block, or AV block. Atria and ventricles, are they electrically connected? It's a tricky question. Are they electrically connected? Can you give me one word answer? Yes or no? Yes, they are. They are connected. Now, what connects them? The AV bundle, right? The AV bundle right here is what connects the atria and ventricles. Not gap junctions, no. Only this corridor. It's like, imagine like two buildings. that have a walkway between them. Does that make sense? Okay? You may have as many windows in those buildings as you want, but you can't jump from one window to another. You have to use the walkway. Right? Same happens here. So if there is any problem at this walkway, if there is any problem in the AV node or AV bundle, the electrical signal that is supposed to reach ventricles will be altered, slowed down, may not reach them at all. That makes sense? This is called a block, or sometimes it is called a hard block. So first degree hard block is right here. Due to the dysfunctional AV node, partially bad, okay, the signal that is supposed to reach ventricles is delayed. So you can see that the time, the interval between the contractions is increased. Does that make sense? Okay. Second degree, when signal does not go at all, it's called a dropped beat. Second degree hard block. Does that make sense? So you have P wave, you have QRS complex, you have T wave. Then you have P wave, you have nothing, and then you have a P wave too. Essentially what happens, you have atrial depolarization and that's it. Ventricles don't contract. And then you have another atrial depolarization and then signal goes through. Does that make sense? Okay. So it's not always, sometimes it cannot get through. If you will take EKG from pretty much any person for a long time, you will see a dropped beat. It happens. From time to time, it happens in even the healthiest person. Okay. So it's not something to get completely freaked out about. Okay. Unlike third degree hard block, when the block is complete, so there's no signal that gets through the AV node. Does that make sense? Rhythm actually will originate more in the AV bundle. And the rhythm that originates in the AV bundle becomes very slow, 30 to 40 beats per minute. It's, now you can tell, what about those athletes? We talk about the regular person whose normal heart rate is around 70. When it drops to 30 or 40 per minute, the amount of blood, the blood pressure in the system drops below the level that's necessary for the life support. So in this case, the person gets the pacemaker. The electrical system that stimulates beating of the ventricles. Does that make sense? Now that was missing stuff, okay? SA node doesn't work, or AV node doesn't work. What if you develop so-called premature beat, extra beat? This is called ectopic focus. Essentially, ectopic. Topic means place. Topos, place. Ecto, out of the place. Okay? When you have a pacemaker cell, sort of a node, okay? Additional node that does not belong to the chain that we outlined. SA, AV, bundle, and then Purkinje fibers. When you have pacemakers somewhere else, it can initiate an extra beat, like this one. So you see the distance between the beats is vastly different from the distance between all other ones. Okay, so instead of doing this, it drops the beat in the center, okay, in between. Does that make sense? Pretty much, it can happen in the atria, okay? In pretty much all healthy people, it can be observed, even in the resting conditions. Again, if you take EKG long enough. Ectopic foci are stimulated by lack of sleep, overconsumption of coffee, or overconsumption of nicotine. Okay, when you kind of feel that extra beat, when heart beats erratically, right? Now, premature contraction in the AV node or the bundle. So what happens is impulse will go from AV node to the bundle and back, okay? So P wave may actually get superimposed on the QRS wave, QRS complex, okay? It's not that dangerous. That can happen in a healthy person from time to time. If it is not a regular thing, then it's not really a problem. It can happen in a healthy heart. Does that make sense? Because if you deal with premature contraction of atria, it is not going to affect the blood pumping that much. Unlike premature contraction of the ventricles. Okay. So you have T wave that has inverted polarity. Okay. The point is, in the premature ventricle contraction, you actually have an extra push for the blood that may not be there. So ventricles didn't have a chance to be filled up with the blood, but they still contract. All the same causes can cause the premature ventricular contraction. And as with previous two things, all these three can be observed in healthy people. What's the deal, you ask? Why we consider it as a problem? Turns out, especially the premature ventricular contraction can be a sign or sign for predisposition to the ventricular fibrillation, which is exemplified here at the bottom. In ventricular fibrillation, muscles of the ventricle contract in the asynchronous manner, okay, erratically, and that means that heart doesn't pump blood. Does that make sense? This is what sometimes the doctors refer to as VFib, ventricular fibrillation. So heart pretty much trembles, but it doesn't pump. Now you notice that I didn't mention atrial fibrillation yet. Okay, so in atrial fibrillation, you pretty much do not see any P wave at all, and you see quite erratic contractions, quite erratic changes between the QRS complexes. So in atrial fibrillation, what happens is the muscle of the atria contract erratically and don't really contribute to the pumping of blood. But it turns out, how to say, it's not that important. I know it sounds awful, but atria don't contribute into pushing the blood into the system or into the pulmonary circuit that much. So pretty much if you get rid of atrial pumping, it will decrease the efficiency of the heart. But people can live with that. People can be in a state of atrial fibrillation and not dying from that. Does that make sense? Okay. Now, before we move on in the cardiac cycle, and that's the things that we discussed before, the valves, the blood flow through the heart, the electrical events in the heart, they were all like components of the puzzle that we're going to put together right now, because we want to trace the contractions and relaxations of the cardiac muscle, electrical activities, changes in the blood pressure, and movement of blood through the heart, opening and closing of valves. Put that all together. Okay? So when I ask you what happens during, I don't know, isovolumetric contraction, you can tell me which valves are closed, which valves are open, where's the blood, which part of EKG is that. It's when you put that all together, it's like a puzzle. Each piece separately may not make a lot of sense. Put them all together, it makes perfect sense. Okay? So all that rambling that I just said is kind of summarized here. I'm not going to read it for you. You can read it yourself. Cardiac cycle. I always try to go from big to small. So heart generally does two things. One, it contracts. Two, it relaxes. It contracts, it relaxes. When it contracts, what happens to the blood? Squeezed out into the circuit. When it relaxes, what happens to the blood? Flows into the heart. Does that make sense? Contraction is systole or systole, depends on where you're coming from. Relaxation is diastole or diastole. Okay, so we can say systole, diastole, systole, diastole. Is that clear? Both sides of the heart, right side and left side, contract simultaneously. Does that make sense? Both sides pump the same volume of blood per minute. Does that make sense? Okay. Since they contract simultaneously, the valves, between the atria and the ventricles, tricuspid or mitral valve, are they going to close at the same time or not? If the sides contract synchronously, the valves will close synchronously. Okay? Why I'm telling you all of that is because we're going to look at only one side. It just doesn't make sense to look at both because they are identical, just different valves that we talk about. Okay? But other than that, so I'm going to use left side as an example. It's just easier because I'm used to say blood gets into the aorta. And it's mostly systemic circulation that we care about. It's the systemic blood pressure that we measure. Okay? We good? So, let's take a glance of what happens in the heart during the cardiac cycle. We start cardiac cycle with the heart being totally relaxed. You just told me a few minutes ago, when heart is relaxed, what happens to the blood? It goes into where? Into atrium. Yes, into the heart, right? Into atrium. Now, it turns out the valve between the atrium and the ventricle is open. Okay? So blood that goes into atrium, in this case it's left atrium, so from which vessels deliver it to the left atrium? Pulmonary Veins. Okay, so pulmonary veins deliver the blood to the left atrium. The valve between the atrium and the ventricle is open. Why it is open? Huh? Let me do one little thing. I'm going to pause the recordings. So here, let me check that this thing is still running. So here, on this one, this grand scheme of things, okay? The valve between the atria and the ventricle is open. Pressure where it is higher? In the atrium, yeah, in the atrium. So doors open, blood flows into the ventricle. Turns out it pretty much like flows almost freely. Atrium doesn't do a lot, doesn't contract. Does that make sense? So that stage is called ventricular filling. At the end of the ventricular filling, atrium here squeezes the last bits of blood into the ventricle, kind of pushes it back. Now what's going to happen to the pressure in the ventricle when it is getting filled with blood? It's going to go up. And I'm going to use the analogy. When it goes up, when tie-in starts to push on the door on that side, stronger and stronger, what's going to happen to the valve? It's going to close. And that's when you hear the first valve sound. So first valve sound is the closure of atrioventricular valves, the lub. That makes sense? They close because pressure in the ventricle becomes higher than the pressure in the atrium. That makes sense. But pressure in the ventricle is still lower than the aortic pressure. That makes sense. Still lower. So we get an interesting situation. We get a situation when the atrioventricular valve is closed and semilunar valve is closed as well. Does it make sense to you? Always think about the pressures. Okay? When I explain it, let me, a little digression, I kind of want to apologize. I incidentally sometimes omit things that I should say. I will say them to you. I will tell you what to think about, okay? So, both valves are closed. Ventricle is continuing to squeeze the blood, trying to get it out, right? Can it get it back into the atrium? Why it cannot? Because of the valve that is closed, right? So the only way for the blood from the ventricle is to get into the vessel. In this case, since we talk about the left side, this is going to be the vessel aorta. The time, the period of the cardiac cycle, when both valves, semilunar and atrioventricular, are closed and ventricle contracts, is called isovolumetric contraction, because the volume of blood doesn't change, right? It's a contraction of ventricle that builds up the pressure inside of the ventricle now. Does that make sense? Yes. Mm-hmm. Mm-hmm.
But the right side has a low resistance to pressure,
Mm-hmm.
and the left side does. But now you're saying both ventricles have high pressure, or we're just talking about the left side?
we're talking about the left side. And your question is, so pulmonary circuit has lower resistance, lower pressure. But in terms of relationships, pressure relationships, on the right side, it's going to be all the same. So only when the pressure in the right ventricle will become higher than in the right atrium, only then the valve will close. Absolute numbers in the right side and in the pulmonary circuit, absolute numbers are lower compared to the left. But we're not comparing sides. It's all on the same. Does that make sense? All right. So where were we? We were at isovolumetric contraction, and finally the pressure in the ventricle became higher than the pressure in the vessel. What's going to happen? So finally the pressure in the ventricle became higher than the pressure in the vessel. What's going to happen to the semilunar valve? It's going to open. And this is called ventricular ejection. The blood goes out of the ventricle into the large vessel. Now think about again the pump and the pipe. Imagine that you have like a hand pump, and you push it and you pump air or water into the hose. Okay? When you do that, okay, what's going to happen to the pressure in that hose? When you pump it in, it goes up, right? Because I mean, sometimes you can see, like when you inflate the balloon, it becomes bigger because the pressure builds up. So when blood goes from the ventricle into the aorta here, okay, the blood pressure in the aorta will start to rise. So blood pressure in the aorta, imagine that as I'm pushing, there are more girls running on that side, and they start to push back on the door. Okay? So I cannot push hard enough. Okay? So when blood pressure in the aorta reaches its maximum, the semilunar valve right here closes. Does that make sense? Interestingly enough, at the same time, the atrioventricular valve here is also closed. So second time I have a situation when two valves are closed. Does that make sense? And that's the moment when ventricle starts to relax. This is called isovolumetric relaxation. When it relaxes significantly enough to drop the pressure in the ventricle below the pressure in the atrium, atrioventricular valve opens. And the cycle starts over again. So you have atria, you have ventricle. Okay? And that's your feeling. They're all relaxed. Ventricular filling. Everything is relaxed. At the end of ventricular filling, atria contracts. And that increases the pressure in the ventricle to the level that the valve between them is closing. Okay? The valve, semilunar valve, that separates the ventricle and the vessel, I have only two hands, unfortunately, okay, is also closed. So ventricle starts to contract, and that's isovolumetric contraction. Okay? It contracts and contracts and contracts, and once the pressure in the ventricle is higher than the pressure in the vessel, it pushes the blood out. Okay? The pressure in the aorta immediately builds up, closes the valve, and ventricle starts to relax. by this time atria is relaxed as well. So when pressure in the ventricle becomes lower than the pressure in the atria, you've got the ventricular filling again. Okay? So this is, I know that's pretty awful and pretty complicated, but I wanted to introduce you first to actual physics, to what happens to the fluids in the heart, so we can put together more things. So here we go. That's time point number 1. Let's take a look at what's going on here at the time point number 1. Atria is relaxed, ventricle is relaxed, heart, blood flows into the ventricle. Does that make sense? We good? Now look at this part of the picture here. So this part shows you the pressure relationships. Green is aorta, blue is the ventricle, purple is the atrium. Okay? So during ventricular filling, the pressure in the atrium is higher than the pressure in the ventricle. That allows the AV valve to remain open. The pressure in the blood vessel right here is higher than the pressure in the ventricle as well, so semilunar valve is closed. Okay? Then atria contract, atrial systole, and that causes the buildup of the blood pressure in the ventricle. Does that make sense? So ventricular blood pressure, the moment it becomes higher than the atrial, it causes the closure of a valve. Okay? And that's the moment when QRS complex is initiated. So atrium starts to relax, ventricle slowly starts to contract. Okay? And then you see that for some time the pressure in the ventricle, although it rises, it is still lower than the pressure in the aorta. So that's isovolumetric contraction. Once the pressure in the ventricle, the blue line, becomes higher than the pressure in the aorta, the green line, that opens semilunar valve, and you can see it opens semilunar valve, and blood is being ejected into the circuit. In this case, it's going to be a systemic circuit, right? The buildup of the blood in the aorta, okay, elevates the pressure in the aorta, which closes the semilunar valve, so you hear the second valve sound, okay? Ventricle relaxes, which corresponds to the T wave on the EKG, okay? Ventricle relaxes, and when pressure in the ventricle falls below the pressure in the atrium, atrioventricular valves open, and the entire cycle starts again. I'm not even going to ask you, is that clear? Because I know that it is not. I'm absolutely serious. The only way you can do it, like you can get it better, understand it better, because maybe some of you have perfect understanding right now, and it's terrific, it's brilliant. But if you don't, take the piece of paper, okay? Picture the heart. First, show changes. Changes in the pressure. Mostly it's the changes in pressure that are critically important for understanding of valves opening and closing. I believe that in the worksheet that's on the blackboard, there is a table where you can put those changes in pressure. Okay, you can do it in any fashion you want. You can say during ventricular filling, ventricular pressure is lower than atrial and lower than aortic. Does that make sense? Please know the relationships of the pressures. It's really, really important. I will ask you. Okay, cardiac cycle, you've got to know that. If you can draw it in any way you want, several questions on the exam. Does that make sense? But I would say the most important thing is if you can imagine, visually understand how it works. If you can see blood going from one side of the heart to another, then you should be good. Okay? I don't remember if I posted any cardiovascular videos, like learning videos yet, or no. You know? I did not. When we're going to take a break, tell me, remind me to post. I'm going to go and I will at least upload several of them. Okay? Just completely forgot about those. Good? It will just help you to visually understand what's going on. It will show you the movement of the blood. It will show you the contraction, the relaxation, and stuff like that. Does that make sense? So when doctor listens to your heart, doctor listens to the heart sounds. And heart sounds will be the valve sounds. And abnormal valves will close with a different sound. But what's more important, abnormal valves will produce murmurs. Okay? For instance, if the valve is not closing completely, the blood will go back. Right? If there's an opening, like AV valve, after the atrial contraction, it still has a little hole in it. The blood will go back from the ventricle to the atria. It will produce sounds. If the valve is stenosed, which means the opening of the valve is smaller than it should be, the blood flow will be altered. It will also produce sounds. There are several levels. Some of the sounds can be barely heard. Some of the sounds can be heard only with a stethoscope. Some of the sounds can be heard if you just put the ear next to the chest. And the louder the sound, the more severe the damage is. Does that make sense? And you see how I slowly encroach the syllable phys in the word physiology. And it becomes so much more important that it's almost physics. And I know how all of you love this subject. I'm included. So when you come to plumbers will probably cringe when I will start talking about plumbing now, but I have to say, okay, you buy the house, okay, you come in and you see it's 3 bathrooms, okay, you're happy, wow, 3 bathrooms, and then it turns out none of those 3 bathrooms work. It kind of sucks, right? So not only you have to know how many, or the anatomy, you actually have to know how well something works. And how can we measure the performance of the heart? What would be the measure of performance for the pump? You have a pump, like a pump. Do you have a pump in a car that will help you to pump the deflated tire? That scares the shit out of me because only one person said yes. well, I do have one too, and I used to have that little thing made by slime. I could have a good lunch while it pumps the tire. Okay, and then I bought another one. Now it's like 3-4 minutes. So what is the measurement of performance? How much, in this case, air it pumps in a given time, right? Does that make sense? So for blood, it's not about air, it's about blood. For heart, it's about blood. How much blood it can pump in a given amount of time. Does that make sense? Given amount of time is going to be 1 minute. Now, the parameter that we talk about is going to be cardiac output. Okay? So cardiac output is the multiplication of heart rate, which is how many beats per minute, how many pumps per minute your heart does. So heart rate is multiplied by the stroke volume. Can you, without, well, kind of spelled out there, but can you explain stroke volume in your own words? How much blood the heart pumps with every contraction, right? Does that make sense? So, again, think about pump that you use to pump the bicycle tire. You can have the big one, okay, and you need just few pumps to inflate the tire, or you can have a little one that you take with you on the trips, and you will spend I don't know, if you don't want to pump frequently enough, you're going to spend like hours inflating the tire. Or you can go really fast because the volume that it pumps is so small. That makes sense? So essentially you can change cardiac output either by altering heart rate or altering stroke volume. Okay? Now, you may say, well, heart rate, yeah, I kind of understand, you know, it can go faster, slower, but stroke volume? We can change how much blood heart pushes out with each stroke? Turns out, yes. Let's go back for a second. When heart fills up with the blood, ventricle fills up with the blood, that's some limited amount. That makes sense. Okay? And then that amount at the end of the diastole, okay, end of the heart being completely relaxed, that amount here is called end diastolic volume. It's the largest amount of blood that ventricle can accommodate. Does that make sense? And then the heart squeezes the blood out. Does it squeeze the ventricle dry? Well, there's some blood left in the ventricle. And that volume of blood that's left in the ventricle at the very end, okay? That volume of blood is called end systolic volume. Right here. Does that make sense? So what is the end systolic volume? If you squeeze it hard, really hard, what's going to happen to end systolic volume? It's going to be lower, right? Like when you squeeze the cloth. If you do just the soft grip, there's going to be some water dripping out of it. The cloth will be really, really damp. If you squeeze it well, it will be closer to the dry, right? And you will squeeze out much more water out of the cloth. Same happens to your heart. Okay? Does that make sense? End systolic volume. The volume of the blood that remains in the ventricle after systole, after the complete squeeze out. So stroke volume will be the difference between the volume that you had in the heart before it got contracted and the volume in the heart after it contracted 100%. So stroke volume is the difference between end diastolic and end systolic volume. So if we want to kind of update that formula of cardiac output right here, cardiac output equals heart rate multiplied by the difference between end diastolic and end systolic volume. Does that make sense? Okay, what's the cardiac output a minute? In 1 minute, a heart pumps the entire blood volume. So adult has about 5.25 liters of blood. So one side of the heart pumps 5.25 liters per minute, which in day amounts to roughly more than 72,000 liters. If you at rest, that's important, if you're at rest, if you're just lying down. 72,000 liters, if you want gallons, very roughly 18,000 gallons of blood every day. Heart pumps every day 18,000 gallons of blood. It doesn't, each side. So one side pumps 18,000 and another side pumps 18,000. It's pretty impressive, isn't it? Okay. When you start to exercise, cardiac output can increase. In athletes, up to 7 times, which is a lot. So instead of 5 liters per minute, it's going to be 35 liters per minute. Okay. The difference between the maximum cardiac output and the resting cardiac output is called a cardiac reserve. So how high can you go with a cardiac output? Okay. Now this table is not because I drew it, but it's really one of the important things. If you can fill out this paper, this table by yourself, it's going to be awesome. So you see, first one, cardiac output is increased or decreased when? Well, let's take a look at this equation. How can you increase cardiac output? In terms of heart rate and diastolic and systolic volume. So activity, how does it change your heart rate? Increases heart rate. So you can increase heart rate. Increase cardiac output. What else? Well, increase stroke volume, right? You can increase the amount of blood that heart pumps with each squeeze. How can you do it? 2 ways. Okay, heart contracts harder, squeeze better. So essentially, you decrease the end systolic volume. Does that make sense? Or can you fill up the heart more? Can you bring more blood into the heart and the end of diastole? Yes. So blood that goes in the heart, which vessels bring it into the heart? Generally speaking. So again, veins, yes. So this blood that goes into the heart is called venous return. Does that make sense? The idea of venous return. Okay? Now when you exercise, venous return increases. When you do any kind of exercise, your venous return increases. Why? Your muscles squeeze the veins and milk the blood towards the heart. Seriously, that's what happens. Okay? So when you exercise, blood rushes back into the heart at the higher rate. So your heart, in the given amount of time, will receive more blood, and that will increase end diastolic volume. Does that make sense? Okay? So this is kind of summarized in here. So end diastolic volume can be increased by either long diastole or increased pressure in the veins, increased venous return. Okay? And opposite things, short diastole or decreased venous return, will decrease the end diastolic volume. And systolic volume, okay, now there's another great thing. When end systolic volume is the amount of blood that is left in the ventricles after the contraction is complete, right? When heart squeezes the blood out, does it have to work against the pressure? When against pressure, where? Where does the blood go? Into the vessels. So it has to work against the pressure in the aorta, for example. If pressure in the aorta is higher, the amount of blood that's left in the heart at the end of systole is higher. Does that make sense? If the pressure in the aorta, the systemic blood pressure, is high, then the amount of blood that's left in the heart after the contraction is also going to be high. Because heart has to work against the pressure. It's harder for it to push the blood out. Does that make sense? If you work out, if you exercise, the ESV, yes, we'll get to the chart. Do you mean the flow chart, the bottom? They not, so this 4 columns, so heart rate is not directly related to the ESV. That makes sense? But you're right. When you work out, your end systolic pressure will be lower. Why? Exactly. Because your heart is working harder to squeeze the blood out. Does that make sense? Now, let's take this table and take illustration using the person, healthy, regular person, and trained elite athlete. So in the normal person, what is the heart rate? 70. The blood pressure? 120 over 80, 120 over 70. Everybody agrees on that? Take elite athlete. What's going to be blood pressure? Slightly lower. So heart doesn't, and we're talking about the rest, okay? They both at rest. So heart doesn't have to work as hard, and since blood pressure is lower, what's going to happen to end systolic volume? I don't know how to. It's really, I can't find any decent analogy. ESV should be lower, yes. To squeeze, yeah. So it can squeeze strong. It doesn't have to work against the pressure. So it can push out more blood. Does that make sense? ESV becomes lower. When ESV becomes lower, what happens to the stroke volume? It goes up. So again, we're talking about the athlete. Stroke volume goes up. What's going to happen to heart rate? In athlete. Yes. So now you start to see why it goes down. If you take an athlete and say those two people, the regular healthy person and the athlete, are of the same size, their cardiac output is going to be the same at rest, right? Because they have same body mass. But athlete has higher stroke volume. More blood is being delivered in circulation with each pump. So the athlete's heart can beat less frequently. Does that make sense? Another thing, many athletes, the heart is bigger. Physically bigger. Because they exercise and it trains and it becomes bigger. Okay? So when it becomes bigger, it fills up with more blood. And with each pump, it delivers more blood into the systemic circulation. So it's not that when you exercise, something like in the CNS will bring the heart rate down. No, because your heart pumps harder with each contraction. It can work less frequently. Does that make sense? Does it? Okay. Now, let me go over the flow chart. We'll take a break. The final point in this flow chart is cardiac output. And I gave you the idea of how different factors increase cardiac output. You can do the same thing for decreasing it, but usually we don't need, there is no physiological requirement, no physiological activity that requires decreased cardiac output. Think about what we do. We are at rest. If we need to run somewhere, we need increased cardiac output. That makes sense? If we do, I don't know, stuff at home, when we move, when we are active, cardiac output has to get increased. So what can increase it? Increased force of contraction of the heart. Because if heart contracts stronger, end systolic volume will go down, stroke volume will go up, cardiac output will go up. Lower arterial pressure, less, what's the word? Resistance to the heart pumping. Again, decreased end systolic volume, increased stroke volume, increased cardiac output. Amount of blood that goes back from the veins. Okay? When we work out, blood is pushed from the veins into the heart by our muscles. Increases the blood filling, the ventricular filling, increases end diastolic volume, increases the stroke volume. Length of diastole, that's pretty interesting. Think about those athletes. If they have 40 beats per minute, with every beat, ventricular filling takes longer. Does that make sense? If it takes longer, more blood will get into the heart. Increased end diastolic volume. Does that make sense? And finally, sympathetic stimulation. Increased heart rate, increased cardiac output. One of the good examples, EpiPen. Along with other effects that it has on people with severe allergies, it increases heart rate. Because when person has an anaphylactic shock, what happens to the person's peripheral blood pressure? Surprisingly. That's why it's called shock. It goes down, and it just goes down. It plunges. Okay? So in order to recover that blood pressure, in order to bring it back up, epinephrine in an EpiPen stimulates the heart rate and also constricts the blood vessels. We're going to talk about it. But the point is, sympathetic stimulation will increase the heart rate, whether it's an exercise or being scared. Okay? It all will increase the heart rate. Does that make sense? Okay. Let's take a break and then we'll talk about mechanisms, how we can regulate stroke volume. Huh? Yes, thank you.